participants of the LDLT conference, let me present to your attention two clinical cases of LDLT. We have two interesting cases of LDLT in young donors, in one case without graft inflow modulation GIM, and in the second with GIM modulation. In the first case, LDLT was performed in a patient with terminal liver damage without portal flow modulation. Recipient's data: recipient A, 49 years old male with weight 54 kilograms and height 170 centimeters, with diagnosis liver cirrhosis, MELD 16, class B according to Child-Pugh, in the outcome of chronic viral hepatitis B plus D, refractory ascites, chronic liver failure. The donor is a daughter, 20 years old, weight 48 kilograms, with a height of 159 centimeters. Graft-to-recipient weight ratio is 0.9%, Raman 32.6%. Intraoperatively, in the weight of the graft amounted to 615 grams. At the same time, the GRWR was 1.1 and the GSVR was 1.4. The portal flow was 292. The portal pressure is 17. According to the latest LDLT consensus, portal vein pressure up to 20 and portal flow up to 300 are allowed for young donors. On the second day after LDLT, reperfusion graft damage developed. Liver markers have increased, and LT 1438 and AST 1259. From the fifth day after LDLT, bilirubin levels began to increase, which peaked on the 10th day and became 599 micromole per liter, which is equal for 35 milligrams per deciliter. According to the proposed new gradation stage for small form size syndrome, it occupies the C stage. From the 7th day after LDLT, taking into account the severity of the patient's condition, the patient is included on the waiting list from a cadaveric donor. A CT scan is presented on the 9th day after LDLT, which shows signs of hyperperfusion damage and a graft necrosite. On the 16th day after LDLT, the patient observed low artery flow. The graft artery stopped being visualized. We performed the splenic artery embolization. After, arterial pulsation restored. Also indications for splenic artery embolization: next points. First, decreased portal pressure and ascites. The second is improved hepatic artery flow. Starting from the 34th day, the general condition has improved. On the 56th day after LDLT, the patient was assigned a CT scan, which showed a decrease in necroscytes. The graft in size increased, blood flow through the portal system and the hepatic artery became satisfactory. Control analysis showed a decrease in bilirubin levels to 26, and INR 1.3 and PTI 60%. The patient was discharged on the 79th day. Second clinical case of LDLT in a young donor with portal flow modulation. Recipient: 59 years old female with weight 60 kilograms and height 163, with diagnosis liver cirrhosis, MELD 17, class B according to Child-Pugh, and the outcome of chronic viral hepatitis B, chronic liver failure. The donor is a daughter, 28 years old, weight 64 kilograms, height 164 centimeters, GRWR 1, GSVR 1.18, remnant 37.3%. Intraoperatively, the graft weight was 510 grams. After reinfusion, the portal flow was 297, as well as a portal pressure of 19. Taking into account the increased pressure in the portal vein and the high flow, we performed ligation of the splenic artery. After that, the pressure in the portal vein decreased to 12. Portal flow decreased from 297 to 235. The post-operative period, biochemical analysis returned to normal on the 14th day after LDLT. The patient was discharged in satisfactory condition on the 19th day after LDLT. Splenic artery ligation should be considered as the first-line GIM option. The second, splenectomy and hemiportal caval shunt, due to their complexity and highly complication rates, should be reserved as the second-line surgical GIM option, and it should be used when a moderate to height reduction in PVP or PVF. is to desire to achieve target hemodynamic. The third, in doubtful cases and/or in borderline cases, it's better to do splenic artery ligation than wait for complication.